بسم الله والصلاة والسلام على سيدنا رسول الله وعلى آله وصحبه ومن والاه. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا واغفر لنا والحاضرين. السلام عليكم ورحمة الله وبركاته. How are you everybody? This is me, Dr. Ibrahim Halawani, cardiac anesthesia consultant. Today, inshallah, we should resume our cardiac anesthesia note about anesthetic management for valve surgeries. To start with, as we are doing in any type of cardiac of anesthetic management, usually we are doing the double C technique. One is the anesthesia consideration of the disease, meaning that how this type of disease you're gonna give anesthesia for will concern you as anesthetist. The second one is, or the second C is conduction of anesthesia, which means how I will give anesthesia to such patient. To have or to understand the consideration of any disease, we need to have some sort of background orientation about this disease. And I also want to highlight something here when I'm speaking about valvular heart disease. I am not taking it entirely from the cardiology point of view. I am mainly focusing on things that will might have implication about your conduction of anesthesia. To start with, small introduction. The prevalence. Is this a common disease? Yani, will I see it in most of the cases I'm seeing? Actually, some statistics say that almost 2.5 of general population will have valvular heart disease, and this problem increases with age. Okay. Another key point you wanted to be totally familiar with is the clinical stages of the valve disease. And this is something very important because as you going through the guidelines or uh, uh, um, outlines of any treatment, you will hear these stages. The stage A, P, B, C1, and C2, and D. And you should understand entirely what they are meant by this one. Stage A, this patient who does not have any symptoms, but he has only a risk factor to develop valve disease. Okay, so this patient does not have any symptoms, does not have any valve disease, but he has only risk factor. This patient, from the cardiology point of view, should follow some sort of treatment and change in the lifestyle. Stage B, this patient who has already valve changes, but it's just mild or moderate, and have it does not have any appearance of symptoms. So when you hear patient is stage B, means this patient does not have symptoms, but he has already a valve change. From C to D, all of these, this patient who has already severe valvular changes, but يعني severe mitral regurg, severe aortic stenosis. But two fundamental parameters you should keep in your head when you assess this patient. What about his ventricular function and what about symptoms? Any patient who has already symptoms and his ventricular function is impaired, this is the last stage, which we call it the D stage. Any patient who has already severe and normal function and no symptoms, in such cases we called it C1. And if the heart function started to impair, so he has two problems, the severe valve and the impaired function, so it's C2. I hope it's clear. Of course, for the treatment and the management, it's an extensive guidelines. I should not go through it, but who wants to go can visit the American Heart Association guidelines for the treatment of such patients and such stages. But what I care about is, the terminology and be familiar with. The risk, usually they said if the patient has a risk less than 4%, we call it low risk, and high risk is more than 8 to 20%, 10 to 20, for example. And prohibitive risk means that the patient has 50% chance of mortality within 1 year. والأعمار بيد الله. طيب, usually what are the treatment approach in patient with valvular disease? What, as you see, we are speaking here broadly speaking. I did not say about mitral or aortic or tricuspid or pulmonary or whatever. I'm just saying patient with valvular disease. Usually, the medical treatment is limited. It's just to manage the comorbidities that will arise, but it will not solve the problem itself, which is the problem in the valve, and the surgery is the only definitive therapeutic option. Okay. Also, over days, in the recent days, we have seen some trends in valve surgery. Like now, earlier you used to see more young patients who came to change the valve because of mainly rheumatic problem or stuff like this. Now, with the increased life expectancy, a lot of elderly patients will come for more valve surgeries because of senile or old age calcifications that will affect the valve. Also, there is a huge tendency to go for valve repair over replacement. As patients who will have valve replacement, they will need a full anticoagulant. And it's extremely difficult for a patient to be compliant with this drug, and he always or she keep this anticoagulant in the therapeutic range for all the time. It's very difficult. So if you able to just do a repair and to avoid the full anticoagulants that he will receive for the rest of his life, it would be better. Also, there is a growing in the percutaneous minimally invasive techniques for different valves and different approaches, and it's gaining every year more and more acceptance and more and more encompassing a lot of patients. I also wanted to highlight some small points for you. Yani, now we are saying valve problem or valve disease. So, what is the normal valve? You should understand what is the normal valve, and this abnormal valve or anything that will happen in this valve, how will it affect the function of the heart? Okay, they call it the valve anatomy. Physiological impact of valve disease. Valve disease will affect the prelude, the afterlude, systolic performance, and diastolic compliance. So whenever you have a patient who said that he has a valve problem, these four things should come to your mind. Of course, we will say it in more details, but keep these four pillars in your head. The idea of this lecture to give you a broad comprehension of the valve diseases as anesthetist. Okay, so patient with heart valve disease, you should suspect that he has a problem in the prelude and the afterlude and the systolic performance and the diastolic compliance. Okay, the other things, all these problems will occur in the heart. It will do two things: ventricular remodeling and neurohormonal activation. These are compensatory mechanisms that will start initially try to compensate the problem that the valve have or the valve has or had done. And the valve will cause a problem in the preload and the afterload and all this stuff. So the body will respond by ventricular remodeling and neurohormonal activation just for compensation. But with time, okay, this compensation will fade and the heart will decompensation. This paragraph, you should keep it in your mind, and we will go step by step to explore what's the situation. Another key point you should be familiar with is the effect of left side disease. If this is the mitral valve or the aortic valve, and this is the heart here, this is the left side of the heart. If I have a problem here in the aorta, or I have a problem here in the sorry, in the aorta or in the mitral, this is the mitral and this is the aortic valve. Usually, there will be some sort of upstream, backstream, sorry, problem for the pulmonary circulation. And as I told you before, we have one lung and two hearts physiological. So the left side of the heart will cause increase sometimes in the pulmonary. And this is a key point. And also something very fundamental I want you to understand that when we say pulmonary hypertension, we have two types, either post-capillary or pre-capillary. If the problem is from the left side, and this is the pulmonary capillary, usually the problem is here. It's after the capillary. So we call it post-capillary pulmonary hypertension, or if it is related to the RV problem, so it is before the pulmonary capillary, so we call it pre-capillary pulmonary hypertension. Okay? Anatomical overview, also something you should know about, which is the that the four valves are in tightly in the base of the heart, and they are anchored by the cardiac fibrous skeleton. Mostly, we told you that the heart is almost like some sort of a bullet, and this is the base of the heart, and this will be the apex. Here you will find the mitral and you will find the tricuspid, or this is the mitral. This is the tricuspid, aorta, and the pulmonary. All of them are here and they are tied together by fibrous skeleton. And that's, if you imagine, that's why, for example, the surgeon are taking suture inside it. If it is a living tissue or it is some sort of conductive tissue or anything, it will be a problem. So, what is the importance of this framework? It supports the orifice electronically. It insulates the atria from the ventricle, and it provides attachment for valve leaflets and myocardial. So, if this is the fibrous ring of the mitral, you will find this is the anterior and this is the posterior leaflet. They are attached here to the fibrous ring. Usually, the aorta is here. Also, there is a continuation like this in the fibrous ring. We have here what they call the trigon or the trigon, and this is the aorta. Which leaflet is this? Anybody still awake? Which leaflet will be this one in the aorta? Those who attend the TE. The right cause? Anyway, so this is the fibrous valve. Now, let's speak generally about the valvular stenosis. Stenosis is narrowing or obstruction of the blood flow through a cardiac valve. Okay. The other thing, it leads to increased blood flow velocity approaching the valve, and pressure gradient will uh, be formed across the valve. And this is the key point that I have here, the valve or the flow. Once I will have some sort of stenosis, the orifice will be less. So here I'll have a laminar flow, here I'll have turbulence flow, pressure here and the pressure here. There is a huge difference will occur between these two, and this difference in the pressure will equal to 4 multiply the V2. Okay. Why we are using this? Because when we use the Doppler effect in the TE or the echo, this is the only or the now it's the gold golden standard way to assess the severity of the stenosis. For the obstruction also, we have two type of obstruction. Something we call fixed obstruction, like we have valvular aortic stenosis, subaortic membrane, and the dynamic. Dynamic is mainly during mid or late systole, and it's load dependent like the HOCM. I will give you a small idea about this one, and we will speak about it in full detail later. If this is, for example, the septum, and this is the aorta, aortic valve here. Okay. Sorry, this is the mitral like this, and this is the ventricle. If you see this area is very huge, okay, this is the LVOT. In HOCM, it's sometimes even enlarged like this. So in the beginning, in the very early of the systole, we can say early and mid and late. What will happen in the early? Some volume will go, and the more squeeze that will occur, okay, it will obstruct here. So the first amount will go easily. The remaining amount will have some obstruction in their way. Okay. So the contraction of the septum, it will push the blood, and on the other hand, it will decrease the orifice of the LVOT. Okay. So the first part of the systole will go smoothly, and the problem will start from the mid and accentuated in the late systole. That's why we call it dynamic. Why it's load dependent? Because if you give good volume, the good volume will combat against this obstruction. And if the patient has already low volume inside the heart, the first small amount will go, and this obstruction will be even more severe. This is for the obstruction or the stenotic valve. What about valvular regurgitation? It's a backward flow of the blood from the due to valve incompetence, causing volume overload and eventually chamber dilatation and eccentric hypertrophy. We will explain every word now. Pathophysiology. Now, let's see if this is the heart. Let's take the mitral, for example. The mitral, when the heart in the diastole, in the stall, okay, all the blood should go through the aorta. But if we have here some regurg, some of the amount of blood will return to the mitral, sorry, to the left atria, while another amount is coming from the pulmonaries. So now the atrial will have more blood that it usually receive in the diastole, in the systole. Once the diastole end, the systole end, and the mitral will open, so the whole amount will go down. It will be more than the heart usually carry. It will be the regurg volume and again the normal volume that it receives. Initially, this what we call volume overload, more volumes that are or the ventricle usually receive. So with time, there will be a change in the preload, and there will be change in the diameter, and there will be eccentric hypertrophy, and we will explain it in 1 minute. Initially, as we said, as we just mentioned, all these compensate, but with prolonged time, systolic function will deteriorate and we will end in heart failure. You remember when we said any valve problem will cause preload problem and the contractility, okay, and afterload and systolic and diastolic problem. We will have compensatory mechanism for a while, and then compensatory will end with failure. This is the sequel. I want you to keep it in your mind. Types of stroke volume. Here we have the forward stroke volume that the blood go for the systemic circulation. Regurgitant or stroke volume, this the blood cross back to the across the valve. Total stroke volume will be both this one and this one. So Usually, if you are dealing with such a patient, usually the treatment or anything is aiming to maintain or slightly increase to support the forward flow and reduce the regurg volume and mild increase in the heart. And we will also speak in detail of this one. Now, as I told you, preload problem, contractility after load, systolic, diastolic, and cardiac remodeling and neuro uh, hormonal problem. What is cardiac remodeling? It's a change in the heart size, with shape, will function in response to acute or chronic pathology. For valvular disease, there will change in the loading, either pressure problem if you have stenosis or volume overload if you have regurg. This will cause, لو volume overload will cause chamber dilatation, and if it's pressure overload, it will cause ventricular hypertrophy. Okay. What is influencing this remodeling? Mechanical stress that caused by either volume or pressure, neurohormonal activation like angiotensin, enzyme activity, ion channel changes, oxidative stress. And again, usually it's initially adaptive, remodeling eventually impairs ventricular performance. And as I told you a few minutes ago, that we have what we call the concentric and eccentric. Eccentrics mean more dilatation than hypertrophy. If this is the wall, this is the normal wall, and this is the normal thickness. If I have more dilatation, but the wall thickness is the same, okay, this is eccentric. If I have the same area, but I have more wall, okay, this is concentric. I hope it's clear now. This is not for us بقى يعني just mention it here just for you. Again, stenosis generally for you more restrictive and hemodynamically severe than regurg. Mitral regurg typically better tolerated than aortic regurg. Aging lead to mild valve insufficiency or sclerosis, impairing valve opening. Okay. Again, stenosis core more significant hemodynamic compromisation. Upstream valve pathology controlled downstream blood flow. Mitral stenosis is the most frequently encountered valve lesion. What you're gonna see in the echo. If it is aortic stenosis, LV is small and concentric hypertrophy, like the one I just do it here, like this one. Small cavity, huge wall. Okay, and they will cause RA dilatation from back flow to the lung and thickened wall level. Okay, mitral stenosis, small LV because no more blood is going down. Okay, aortic, massively dilated. The LV, if we have aortic regurgitation or mitral regurgitation, is dilated LV. Later on, we will take every one in more specific details. Uh, this is also a key point. Don't get fooled by ejection fraction. It's sometimes it altered by the remodeling. يعني L diastolic LV end diastolic volume and end diastolic diameter are more important value. Also, diastolic function always impaired. Heart will not be able to relax well. So give good preload and don't increase it too much. It will not tolerate. And heart rate should be also kept in the normal area. Concentric hypertrophy, usually the function, systolic function is preserved, but mostly he has diastolic dysfunction and higher risk for myocardial ischemia. And as I told you, most valvopathies are low intolerance to hypovolemia and also low intolerance to hypervolemia. Right. Now, after we spoken about all of them, generally speaking, let's target the aortic stenosis and start with it. Aortic stenosis is the most common reason for valve surgery in Europe and North America. We have two types of aortic stenosis. Congenital, this patient who has already unicasp or bicasp, okay, and they easily get calcified and early get stenosis in the aortic valve, or acquired, like degenerative in the old age or rheumatic in patient with rheumatic heart disease. The stenosis can occur on three levels, either in the valve itself or below the valve or above the valve. Now he's speaking a little bit about the degenerative. Okay, it's mainly about age. The more aging, the more inflammation that caused in the valve and the progressive calcification. This is the magic word. Progressive calcification usually it's affecting around 2% of men more than 65 years old, and 5% of patients more than 85 years. And the higher calcification, the worse in the prognosis. And this type of patient are now with the increase of age expectancy, we are seeing them more and more now. Of course, normal risk factors you all know about: dyslipidemia, smoking, hypertensive, diabetes, serum calcium, creatinine, and male. Of course, female will not die; they will let us die first. Okay, clinical correlation: angina and coronary artery disease. Now, what will happen? We'll take it by here step by step. What will happen with aortic stenosis? Okay, aortic stenosis progress هيحصل will have an increase في pressure gradient between the LV and the aorta to preserve the stroke volume. This is initial. But this pressure will cause pressure overload in the LV, triggering a compensatory mechanism we spoke about, remodeling and the hormonal, and we will end with concentric LV hypertrophy. This what lead to what? Increase LV and the diastolic pressure, reduce diastolic compliance and diastolic dysfunction. Hypertrophied LV is a great risk of myocardial ischemia. Why? Elevated LV end diastolic pressure and reduce coronary perfusion pressure and increase myocardial demand and coronary microvascular changes. So let me explain this for 1 second and continue. Usually, the coronary problems is between the demand and the supply. صح? Here we have hypertrophy. This hypertrophy will increase the demand. More muscle, more oxygen needed. But what about the supply? Supply the coronary perfusion pressure is equal to diastolic pressure minus the LV and the diastolic pressure. What's this? Imagine it with me now if this is the LV, okay, and this is the coronary artery. We call it the epicardial coronaries, okay? Now, here inside the perfusion occurs during diastole, as we know. This is the first flow in coronaries. It occurs in the diastole. So it goes from this pressure here and this pressure here inside. So the difference between this one and this one are the driving pressure that will cause the blood to go. This blood pressure is which pressure is the diastolic blood pressure of the patient, and this pressure is the diastolic pressure inside the LV. So patient who has high LV and diastolic pressure, this one will be high, and usually not all the time, sometimes the diastole are not increasing well. So let's assume that it will not be either normal or a little bit low in the aortic stenosis. So the difference between the diastolic and the LV and the diastolic pressure will be less. So here I have less supply, but I have more demand. So again, Hypertrophied is a great risk for myocardial ischemia. Why? Elevated LV and diastolic pressure, reduce coronary pressure, increase the demand, and also the microvascular changes reduce capillary density. Okay. And once this problem occurs, this ischemia will increase more the diastolic dysfunction, creating a vicious cycle. Okay. So in your mind, this is a huge problem, and we care about it a lot in patients with aortic stenosis. Now, clinical presentation. As I told you in the very beginning of all this, we have class grade A, grade B, grade C1, C2, and D. Okay. Some some trigger points we are seeing. Many patients symptomatic for at the time of diagnosis. Systolic murmur may be the only detectable sign. Symptoms typically appear late. So when I speak about AS, it appears late. And once it occurs, it's a poor prognosis. So it occurs late, and this is something, yeah, very characteristic to the aortic stenosis. That that the symptoms occur very late, but once it occurs, means that life expectancy is very low and the prognosis is very low, and you need to run with the patient as fast as possible. Okay. Aortic valve area is decreasing by 0.1 per year, and the gradient is 10 per year. Echo, as I told you, is the gold standard now for the diagnosis. Earlier, they used to take the cast, but not anymore. This is also something that they call low gradient, low flow. When they, as you know, or as we just said, we are measuring the stenosis by measuring the gradient. Okay, and the gradient here, for example, in the aorta, B1 and B2. Okay, so the difference between B1 and B2 is what they will tell you about the degree of stenosis. The problem is if the patient has already low ejection fraction, this means that his B1 will be already low. So the difference between B1 and B2 will not be high. And if the difference is not high, this means that no significant stenosis. But if you try to measure this area, you will find it very small. Okay, so that's what they call low flow, low gradient. Type. How I make sure that this patient already has low, or it's just because of the low ejection fraction? They give him dobutamine stress test. They give him dobutamine. Dobutamine should improve the ejection fraction, and it will increase the B1. So if the B1 minus B2 after I give dobutamine and after I saw that ejection fraction improved, and I found that there is a high difference now, so this is the true one, and already we have a significant stenosis. But if I give dobutamine, and there is no change in the ejection fraction, okay, and no increase in the BI, or there isn't, يعني, this does not affect the different pressure. So after this occur, خلاص, still low. So sometimes this is a true stenosis. Okay. You will usually see it in the report of the echo. They will say ejection fraction, and with this ejection fraction 15%, for example, the gradient is, for example, 10. And then now we do the W, it increases the ejection fraction to 35, and it's 25 now, the gradient. So this is a low flow, and there is a true stenosis. Now we diagnose the aortic stenosis, we understand everything about it, what they are doing for it. They either doing surgical treatment by SAVR, surgical aortic valve replacement, or TAVI, and sometimes we call it TAVR in some areas, which is transcatheter. Earlier, TAVR was for high risk. Now, after partner 3 and or evaluate, evaluate trial, now they are giving it even to low risk surgical patients. SAVR, usually the one we are doing in the OR, surgical. Either you will vote mechanical prosthesis or biological. Okay. All prostheses have a sewing ring. Yeah, and we will not speak also about it. Better to leave this one to the TE. Technique to enlarge the heart. Sometimes, if you wanted to replace the mitral, the aorta, and keep it big, use a stentless prosthesis or do batch enlargement or homograft or do Ross or Bental. Okay. But as I told you, this is we'll discuss more if we are speaking about the TE. Now you have a patient with aortic stenosis and he's coming for SAVR or surgical aortic valve replacement. We said in the beginning, I told you C and C. Consideration. Now you have all the consideration you want to know about the aortic stenosis. Type. The conduction of anesthesia. Conduction involved 4 B's. B for patient and the procedure, presenting illness and place. This in all type of anesthesia management. Patient, what type of patient you are dealing with in the preoperative, you will see in the demographic. This patient is old or young. Yani this patient is 40 or not, or he 80 or 90 years old. The procedure here is SAVR, surgical aortic valve replacement. Okay, and we will speak about in detail. Presenting illness, this patient came with aortic stenosis, and this aortic stenosis has symptoms like, as we said, coronary artery disease, okay, syncopal attack, okay, arrhythmia, heart failure, all the problems that the aortic stenosis will cause, diastolic dysfunction, and the place. Surgical, it will be done in the OR. TAVI could be in the cath lab or hybrid OR. Okay, now you have all the consideration about your patient. Let's see what we're gonna do. Preoperative, we will take history. As I told you, 5 CAD. Usually we need an angio, or make sure that the 5, which are 4, FIVE, the function, the ischemia, the valve. We know aortic stenosis, any other valve problem, LE for any arrhythmia. Okay. Now I also examine his vital. Patient is hypertensive, hypotensive. Patient about airway, is it fine or not? And local line way also. And examine him from head to toe. And you will go for investigation. Usually this patient will have the labs of complete CBC, coagulation profile, liver function test, renal function test, electrolytes and glucose. If the patient is old, you must have carotid ultrasound, chest X-ray, pulmonary function test if the patient has lung problem, and do ABGs, ECG, echo, and angio. This is very important to know the function, is systolic function or diastolic dysfunction. When the patient came for you in the recovery area or the pre-induction room, you should recheck the patient, additional, and recheck your plan. Do additional local airway to see if you're gonna need any something. Blood, bed, and the consent is very important. And then pre-medication. Here it will help you to reduce the anxiety and reduce or prevent preoperative tachycardia and myocardial ischemia. If you remember last time when we speak about the revascularization in the coronary artery disease, tachycardia is a huge problem because it will increase the demand and it will decrease the diastolic time. Okay. Okay. Now you saw everything. You saw the patient and you push the patient to the OR. Prepare your OR, anesthesia machine, monitors, warming blanket, ultrasound, airway trolley. Prepare your anesthesia drugs and the cardiac. Pre-induction. The monitoring, we have the standard monitoring, 5-lead ECG. And as I told you last time, monitoring the ECG for ST is very important in this patient particularly, like as if he's a patient for coronary artery disease. Okay, pulse oximeter, nurse, all of these, and definitely you will have a pre-induction A line and baseline vitals. You should take it because baseline function will be your guidance. You will know how heart rate and what diastolic pressure and what mean pressure are favorable for this patient. If the patient is lying flat and calm and no chest pain, nothing, خلاص, you know that this heart rate with this diastolic pressure, with this mean pressure, all of these are excellent for this patient. Before induction, make sure you have a large bore peripheral venous cannula, or even if the patient has low function, it's better to put central line before induction. Okay? And prepare external defib because this patient, in such patient particularly, he will not tolerate any arrhythmia. So any arrhythmia in patient with AS, directly cardiovert. Okay? And as I told you, central line, if the patient has low ejection fraction, or as we said, hemodynamic instability before induction. Okay? And also take care, you try to give him sedation, oxygen supplementation, and all this stuff. You don't want the patient, while you are putting the central line, to get an anxiety and to get hypoxic or to get tachycardic. What you're gonna gain with the central line, you're gonna lose because of the irritability of the patient. Okay? The other thing, should we use the pulmonary artery catheter? In such a patient, we have non-compliance LP, so pulmonary wedge pressure usually unreliable. And also induce the risk of hypotension from arrhythmia, which is very important and very lethal to patients with AS. Okay? So sometimes they put the sheath and they put the cath and just float it after opening the sheath or even in the bypass. And usually we keep it for a patient who has low preoperative ejection fraction, and it will help to measure if the patient has pulmonary hypertension. For the induction, what is your hemodynamic goals? Preload increase. Okay, this patient cannot tolerate hypovolemia. Contractility maintain all the time. After load, either maintain or a little bit keep it all the way. If this patient loses the tone of the after load by significant vasodilation, the patient will collapse because he's depending on the good after load for the perfusion of the coronaries. So maintain and vigorously treat with it. يعني vigorously treat any drop في الافتر لود. Okay. Also sinus rhythm, make it from 50 to 70. Less than 50 is not favorable. Why? Less than 50 will increase the incidence of idioventricular rhythm, and it will cause problem and arrhythmia, and also might cause huge problem. More than 70, it will cause also tachycardia, and this also will increase the myocardial demand. Okay? Careful. Titrate the anesthetics. Okay? Keep the hemodynamics in your eye. Okay? Whenever any problem occur, vigorously, especially this problem adjustment, give good preload. Okay? Acceptable. Maintain the contractility. Don't give high SIVO in the induction or huge doses. of propofol. Okay, titrate very slowly. Whenever the pressure started to go down, vigorously keep it up. Avoid vasodilators, or deep anesthesia when managing the hypertension. Then intubate. Okay, if you did not put the lines before intubation, put it after intubation. Then 3T, tie TE, temperature prop. TE here is very important. It help you with the function, the prelude, the afterload. You can measure the annular size for the valve, assessment of the prosthetic valve after they bought it to exclude paravalvular leak, residual valve gradient, or valve abnormal movement, and all the things you will see in the. Okay. Now they will start draping. Usually, almost of the time, I said in the time of draping, it's a time of low surgical stress. Patient prone to hypotension and arrest. Okay, so keep in mind, don't give your back to the patient in such time. Skin incision is time of high stress. Here we'll have hypertension. Sternotomy is the same. Here we don't have harvesting unless they're gonna do additional capture. So prepare your heparin because once they will open the pericardium, they will ask for the heparin. And they start cannulation. They will go on bypass, weaning and post bypass. Some tricks point I need you to be aware of. Myocardial function and stroke volume improve quickly after bypass. Okay, the function will get better, stroke volume will get better. By hypertrophy will resolve more slowly over time. You will need a good or high preload in the post-surgical period. Don't keep the patient hypovolemic because of the thick myocardium mass. Increased myocardium mass, reduce coronary, as we said, might lead to suboptimal myocardial protection during the cardioplegia. So make sure that the patient received a good dose of cardioplegia, and it's better to give it through the root and also retrograde. Okay, because this patient has huge myocardium. And post bypass, if he did not receive a good cardioplegia and a good myocardial protection, usually he will have LV dysfunction. In patient with hypertrophied septum, as I showed for you, keep him good volume. Don't to give any inotropic support because dynamic LV outflow tract can occur and the patient might go in the risk of hookup. Also, the aortic valve replacement, post-operative complete heart block could happen, and sometimes they need pacing. Sometimes. After they did, we did the hemostasis, the closure. If a patient is eligible for fast track, he will be extubated. Otherwise, he will be transferred to the ICU and hand over for the ICU stuff. Okay, that will be all for today. جزاكم الله خيرا. السلام عليكم ورحمة الله وبركاته.